Hey guys, it's been already 2 weeks since last time I kind of gave an update, and time's already starting to somewhat fly by. It just felt like I was talking, about the last 2 week update not too long ago. But things have been good. I wanted to the last kind of go over last 2 weeks of residency and what I've been up to. I finished up on inpatient psych and started on what's called BHAC and the Consult Liaison Service of Psychiatry, kind of an intro to that. First I went to BHAC, which is an acronym that stands for Behavioral Health Acute Center, which is offered at the VA. And essentially what it is it's an urgent care for mental health needs, which is a pretty cool idea, to have a place that's maybe kind of bridging in between seeing an outpatient provider, whether that's a family doc or a psychiatrist, but not quite to the extent where you feel like you need more immediate or emergency care and need to present to the emergency room. So it's kind of a nice medium between the two of them for veterans to be able to walk in if they need to, because of a concern that they have, as well as we do some scheduled appointments as well. So let's say someone that we saw in the hospital that is discharged from the hospital, but still doesn't have an outpatient psychiatrist yet, or they have yet to meet with them. Sometimes, or I should say a lot of times, we bridge them over to BHAC to see a psychiatrist, or see the psych team, and follow up on them, see how things are doing, see if they need medication refills, see if the meds that they are currently on are working okay for them, if we need to make an adjustment, and just kind of bridge to that outpatient. So those are typically the two situations: is you're a walk-in patient that needs something somewhat urgently, or there's a concern, or this is a scheduled bridging appointment just to make sure things are going okay after you've recently been psychiatrically admitted to the hospital, or something to that effect. You're following up, but it's a scheduled appointment. And I really liked the idea, but I did find that for me it has not been my favorite psychiatric experience thus far. In fact, I'd say up to this point it's probably my least favorite, which is surprising to me. I thought I was really gonna like it. I think what I've found about myself is that I really like knowing what I'm getting myself into. And I guess what I mean by that is having scheduled appointments where I know who I'm going to see, I know when I'm going to see them, and I can look at their chart, I can review their history, I can really have a pretty good idea of what I'm going to be seeing them for, already kind of coming up with a tentative plan. I just kind of like having that preparation. As opposed to with BHAC, I would say the vast majority of the patients that we see over there are walk-in. So they'll walk in with a need. We get their information so that we can look at them briefly, like as far as like a chart review. So I can look in their chart and see, do they have kind of a psychiatric history? Are they on any medications right now for mental health? And kind of do a really quick and dirty, like, just give me a quick idea of like who this person is, before I see them, which I think some people really enjoy. That fast-paced, I don't know anything, like just let me do my thing, let me start from scratch and kind of say like, okay, like let's walk through the whole psychiatric interview and let me figure out what's going on. And that is interesting, but I've just found myself that I very much like the additional prep that I can say, and it helps me lead a lot of questions, because I already have somewhat of an idea of what I think is going on, or I have an idea of their history, and so I can just ask about it. Hey, I saw you were in the hospital around this time. Tell me about what was going on. during that time. Like I can ask that question if I know that they've already been in the hospital. So I think it just stylistically, that's how I like to operate. And so BHAC, when I did that for a week, was like a more challenging rotation. I think it is good for those quick skills of trying to triage very quickly. And really, I should say, BHAC, I think, as it was initially intentioned, was to help be able to determine if people really needed more emergent care. So whether or not they needed to present to the emergency department and present for inpatient psychiatric hospital admission, versus is this person stable or in a place where we can send them home comfortably and they can follow up with their outpatient provider. And so that's kind of the call, I would say, like, or maybe the question, and we'll kind of get into that with consults. But that is, I feel like the question that you are answering as a BHAC psychiatrist is does this person need to be admitted to the hospital, or are they safe for outpatient follow-up? And I think what's been interesting, and I'll get into this in a second, but is that there is this art of psychiatry where some psychiatrists' answers to the same question might be different. So whether someone is safe to go home, what does that mean? Like there's some hard and fast rules, right, where it comes to individuals who are at acute risk or immediate risk of harming themselves, harming another person. Those are hard stops. Those are things that we will address immediately. But there's kind of this gray area of, let's say, someone who has chronic suicidality and is presenting because they're depressed and they have had kind of a rough go around the last couple of weeks and they're not sleeping very good and they've just kind of noticed that they're downtrending and are here to get some help. And that's someone that, as you talk with them and explore, you sort of develop in your mind a risk assessment of, do I feel comfortable with this person going home with this plan, or do I need to escalate their care to inpatient psych admission? And that's just really, like, ultimately what I think the question at BHAC is all about. So that's kind of interesting. And then and then you just don't know what's going to walk in the door. So sometimes you'll have something that will walk in the door and you're kind of like, it's kind of like a normal urgent care where it's like you have varying degrees of acuity or severity. So you might have, someone who's just looking for something to help them go to sleep because they've just really had some trouble sleeping. So maybe their PTSD is really bad. They keep having nightmares, so they are very distressed and can't sleep great. And so they just really need some sleep aid or something to that effect is what they're kind of looking for to help them. And that's a little bit more straightforward than maybe someone who is, again, presenting for a safety concern. Maybe they're having very new distressing symptoms psychiatrically. Maybe they're hallucinating or something like that, where, again, like, we have to work this up more thoroughly. We really have to understand what's going on. And so it's just kind of, again, just the variety of patients that can present, which I think some people really enjoy. And I think I enjoy it so long as I feel like I don't know, I'm not a huge fan of being caught off guard, and maybe that's very, I don't know how to say, but like, that might not be the best of me to say, because ultimately, like, I want to feel like I'm prepared to handle anything, I guess, is where I hesitate with that, is because I want that skill. I just know that on the day in and day out basis, I think I would prefer to have a little bit more of that structure of, this is who's on the schedule, and then maybe having an open slot in the day where it's like, and this is the time for if one of my patients needed to be seen more urgently for an escalation of care or concern that they had, that would be available to them. And so maybe that would be the one where it's like, now you're just going in and go figure out what the problem is and treat it, versus having just that, again, just that little bit of extra preparation, I guess. But BHAC was really interesting. It was kind of feast or famine, and that's the other thing that's kind of nice for some people, I think, is that at times maybe you'll only have one patient walk into the clinic in the morning, and so you've seen like one patient, and so otherwise you've just kind of been chilling, like you're just kind of on standby until you're called. And then other times you've got like 5 people that walk in at the same time, and so you're trying to treat a lot of people very quickly and understand, and you're just slammed, and so it's kind of feast or famine. And so again, something that I'm less of a fan of. I like some level of structure, I think, and knowing what I'm getting myself into. But I think a lot of people enjoy that kind of feast or famine approach, and sometimes you have really light days and sometimes you have really busy days, and some people really enjoy, I think, that variety. So, but yeah, that was kind of BHAC. And then my other week this week has been on the consult service, which is a really interesting service to be on. Essentially, what we are doing is we are available to the various hospital teams, specifically usually the medicine team. So the internal medicine and the medical floor will typically put in a consult if they have, let's say, a patient that is medically admitted for something, congestive heart failure, COPD, maybe they had a stroke, or they have Parkinson's disease. They have, we saw a lot of that. They have kind of a quote unquote medical reason why they're admitted to the medical floor that the medicine team is handling. And then a psychiatric concern pops up. So let's say the patient on the medical unit suddenly starts, saying that they're having thoughts of hurting themselves or hurting someone else. So like a safety question or a safety concern that pops up. Maybe they're suddenly starting to hallucinate, or like become confused, altered mental status. That tends to really concern the medical teams, and they like to get us involved pretty quickly to kind of help triage what is the cause of this acute change in mental status. So those are a lot of the consult questions, and I kind of mentioned I was going to allude to that, that I was alluding to earlier, I should say, when I said, what is the question? And as a consult service, that's always really what you're trying to do, because you aren't doing a full assessment necessarily. You are trying to answer a specific question that the consulting team, which is usually the medicine team, is asking. So again, let's go to the safety concern. This is a common one that we would get on the consult service, is like patient says something that's concerning for safety, for self-harm or harm to someone else. We need to know if this person is an acute risk of hurting themselves or hurting this other person. Do they need a one-on-one sitter? So someone that the hospital provides who will sit outside their room, make sure that they are okay, and will watch them to make sure that they don't engage in any of these types of behaviors. Does this person warrant that level of care, is the question that they're asking. And so they put in a consult, we get it on our EMR system, we say, sure, we're gonna go see you. And so we then make our way over to the hospital in the morning, and we interview the patient, and that can usually take between 30 minutes and I'd say like 45 minutes or so, sometimes up to an hour if you really need it. So you can do a pretty complete interview to really kind of have a good idea. The safety questions, a lot of times folks, at least in the brief period that I was doing it, will say lots of kind of these safety concerning questions, thoughts of, I might be better off dead or something like that, really to express the level of discomfort that they're in because of maybe chronic pain that they're dealing with. Like this one guy that I was seeing who just had chronic nausea and abdominal pain for decades, and was just like, I think he made a statement in the ER that was something along the lines of like, I just wish this pain would all go away. I just wish I would like wake up or not wake up because this is so bad. And they consulted us because of that statement that was made to kind of further evaluate. And ultimately, he was a pretty low risk for actually, from the safety perspective. But it was because of that statement that we were consulted. Other times we get consulted a lot for neurocognitive disorders, so Alzheimer's, Parkinson's. Sometimes in those disease processes, especially towards the later stages, they can become quite confused, which is typical, especially in the late stages of those diseases, but they can actually start to hallucinate, and they can start to have these pretty strong delusions and delusional thought processing. And so kind of trying to differentiate between Parkinson's psychosis and, let's say, schizophrenia, or more of a kind of a different cause. Like, essentially it's trying to better distinguish like what is the cause of these visual or well, actually, interestingly enough, a lot of the time it's visual, but classically the most common psychosis in any patient is auditory hallucinations. So hearing voices, that is the most common. But interestingly, a lot of times in these Parkinson's psychosis, they will have more visual hallucinations, which is a little bit atypical than something that you would see maybe in schizophrenia or bipolar mania with psychosis. Is typically that's more auditory. They can have visual hallucinations, but it's just kind of interesting stuff like that. And so we evaluated a couple folks for Parkinson's psychosis, and it's tricky, because you ultimately kind of end up managing them the same, as you would, well, I should say slightly different, but similar medications. You can, it's kind of this interesting bridge between neurology and psychiatry, where we're both kind of involved, and we have different opinions, I suppose, on how things should be handled. A neurologist has some medicines that they really like for Parkinson's psychosis, and psychiatrists have some medications that they really like, and those can be different. And so it kind of depends on which service is consulted and on the varying opinions of whoever is giving the recommendation. And at the end of the day, that's another interesting part about the consult service, is that is what you're doing, is you're giving recommendations. Like, we are now following the patient. We are now attached a little bit to the patient. So we're following up on them, making sure things are going okay. If we recommend a medication that would be helpful, we don't order it. The medicine team who placed the consult ends up ordering it because we recommended it, but then we follow up on it and make sure that, let's say, like, we start someone on Seroquel or quetiapine, which is an antipsychotic that we give a lot of times. It could be really helpful at nighttime, help people sleep, but also treat hallucinations and psychosis. But it can also make people sedated. It can also make people dizzy. And especially in someone who's maybe a 75-year-old fella who has Parkinson's disease, who's already unsteady on his feet, that's something that you would want to pay close attention to, and make sure that you're not increasing risks of falls, and things like that. So just stuff to keep in mind. So it's just the consult service, I think I enjoyed a lot more, because I thought I liked, again, knowing that whoever was consulting us would be asking a question, and it was like, ultimately we are just trying to answer this question, and we just give recommendations based on our evaluation of the patient from a psychiatric perspective. And that was kind of cool. Again, similar to BHAC, it's feast or famine. So sometimes we would get 4 new consults, and that takes up your whole morning into the afternoon, and you end up staying till like 5, just writing notes, just writing all the recommendations and discussing it and stuff. And other times, and then you're also following up on the patients that maybe you saw yesterday, to make sure that things are going okay. So sometimes it's really busy, and other times maybe you're not needed, and like you don't have any consults in the morning and you have one in the afternoon, and so it's pretty chill. So again, feast or famine, not those types of I guess areas of psychiatry I tend to not enjoy quite as much, but I did enjoy the consult service more than the BHAC service altogether. Really cool to, one of the cool things about the consult service was I got to work more closely with our program director, who is a forensic psychiatrist, forensic trained, and she is just a really awesome psychiatrist, and I don't have a lot of opportunities to see her interview and talk to patients necessarily up until that experience. And so it was cool to I really enjoy seeing attendings in action, and you just see styles and you just see different ways of approaching the patient. Interestingly, again, something that I alluded to earlier was that different psychiatrists can look at the same situation and answer differently. And so there's this nuance of what do you feel comfortable with and what are your impressions, and that can be different from someone else's. And so I was seeing this patient on consults with one of my co-residents, and I thought I didn't really do much. I was mostly just observing, but I thought that she did a really amazing job of trying to come up with a really reasonable treatment plan that was a safety plan for this patient. The patient was dealing with a personal circumstance where their father-in-law had just passed away. They were trying to go to a funeral, debating on whether or not they needed to be admitted to the hospital or if he could go to this funeral and then come back for reconsideration. And anyway, the attending that we were working with was pretty strongly of the opinion that this patient needed to stay, that they did not feel comfortable with them leaving, and that if it came to that, they would put them on a hold, which we talked about last time. I and my co-resident saw the situation a little differently. I think that if it were up to me, which luckily the situation didn't come down to this, but if it did, I think I would have been more inclined to not put them on a hold and instead to actually allow them to go. And so it's just kind of interesting. And she also went through different attendings that would be like, yes, like this person, this attending, these people would all have probably let this patient go, and these attendings would probably admit this patient. And so it really just comes down to, what does your clinical experience tell you, and what does the patient present like? Did they say, what are their risk factors, what are the protective factors? All of those things come into the equation, and it just kind of depends on a little bit of how you feel about it and who's ultimately making that decision. So yeah, that was kind of interesting for me to learn too, was to kind of be like, I understand why the decision was made, but I think I would have made a different decision, and here's why. And I felt like the attending could say, this is why I think this way about this decision, and here's why. And both can be correct. It's just kind of a difference of style, opinion, and clinical experience, and just your impression of the patient. So that stuff I think is actually really cool. And why, again, I kind of like psychiatry, I think, is that there is this level of, I'm going to make this call because of these reasons. And maybe that's the wrong call, but I have some good reasons why this is, I feel confident that this is the correct call. And that often that's good enough, regardless of what decision that is, so long as you explain your thought process and your assessment and why you're doing what you're doing, that it could be totally appropriate. whichever way. And I just think that's actually kind of cool. And it allows you to, I don't know, have a little bit of freedom, independence, and just an ability to think critically and independently, I guess, and just say, this is my impression, and it's okay if your impression is different than someone else's impression, and that's just the art of psychiatry. Yeah, anyway, so cool stuff. But hopefully that gives you a little bit of a glimpse into what BHAC is like, what into the consult service is like. This past week, I've also been involved in the correctional facilities, so at the prison system, and I will be there for the next few weeks. And so next time I will give you the rundown of prison life, which is very interesting, quite different than any experience I've had up to this point. But I will save that for next time. So until then, I'll let you guys go. Have a good one.